Hello? Can you hear me?
Yes, Dr. Massimo, we can hear you.
So, who is the leader of this group?
Machado.
Machado. Okay. Hi, Machado. So, can you introduce the group to myself so I can know them? From which country they come? Where do they work? 5 minutes only to know how I can deal to this group. Okay. I unmute my phone, my laptop.
Hello, good evening, good morning, everybody. My name is Dr. Machado. I'm from Tanzania, working at Weill Orthopedic Institutes. So in the group, I think we have a number of participants from Tanzania, Kenya, Sudan, and some other countries. So today we have Professor Maximo, who is going to take us through the adolescent idiopathic scoliosis. So I think everyone should say at least hi to everyone. At least introduce yourself for 1 minute. Welcome. Yes, Albert.
Hello, everyone. I'm Albert Macha. I'm an orthopedic surgeon here in Tanzania. It's a pleasure to be here, and thank you very much.
Hello. Rabieli, are you around?
Hello, everyone.
Yes.
My name is Kenneth Nyombi. I'm an orthopedic surgeon from Kampala, Uganda. It's a pleasure to be here.
Thank you, Kenneth. Next one.
Hello, everyone. My name is Brian Malao from Zambia, Lusaka, orthopedic surgeon.
Welcome.
My name is Imad Ibrahim from Sudan. I'm a neurosurgeon. It's a pleasure to be here. Thanks.
Welcome. Next one.
Hello, everybody. My name is Akim Mageza, orthopedic surgeon from Harare, Zimbabwe. I'm delighted to be in this group.
Welcome, Mageza.
Thank you.
From Zimbabwe. Yes, Sura.
Hello, my name is Stura Lufira. I'm a senior registrar with the COSEXA and I'm in Namibia.
Thank you, Sura.
Hello.
Hello.
My name is Ben Gadua. I'm a neurosurgical resident with the COSEXA program from Nairobi, Kenya.
Thank you, Ben. Next one. Yes,
Hello.
Hello.
Hi, I'm Azares. I'm a neurosurgeon from Addis Ababa, Ethiopia.
Next one. Hello. Yes, can. Anyone who hasn't introduced, please.
So, Ken Keller, Kumvenda, can you hear me?
Ken Keller.
Ken Keller. So everybody is connected. How the connection are working? Can you hear me well?
Yeah, I can hear you.
Yes, we can hear
Yes.
you.
Yes, please, we can.
Okay, so we can start this discussion, and so you have to unmute your laptop, with Zoom, and some question rising as have risen for the Larry Lenke lesson. The presentation was very nice and clear. So any other kind of question rising from his presentation, I can answer probably. You can type in the chat, or you can unmute your phone and then ask me.
Hello, can I start?
Everything was. Who is speaking?
Dr. Mcharo.
I'm Charo. Okay.
Yeah, thank you. I think one of the things which was clearly clarified is the use of neuromonitor.
Yeah.
In doing big surgeries. Unfortunately, neuromonitor is something which is neuromonitor is not easily available in most of our countries, especially the hospital where I'm working. So there are other modalities which has been practiced, like wake-up tests. I don't know what's your comment on the wake-up test. We have a number of patients whom we did scoliosis surgery using this technique, I mean the wake-up test, and it worked fine. So what's your comments on the wake-up test, especially in a country where we don't have neuromonitor? Thank you.
Okay, so great question. The problem is the resources that you can have in your hospital, as you said.
Yes.
In the past, when I'm doing a spine surgery since 40 years. I started when I was very young, and at that time, we didn't have instrumentation in the surgery in the theaters, and we used at that time only the Risser technique. Do you know what is the Risser technique? That you do a posterior arthrodesis. You can you cut the laminars and the articular joints with a Ranger and with a Carison and all the tools to create a plate, a tool, a bed for the spinal chips. And after this, you close the skin, close the muscles, and go to the correction with a plaster cast. At that time, we didn't use neuromonitoring because there is no correction in the theater. The correction of scoliosis was done with a plaster cast. After this period, we started to use the Harrington technique. What is the Harrington? Harrington is a rod where you put a hook in the upper part of a curve, another hook in the lower part of a curve, and you start to distract the spine. Of course, in that period, we didn't have the tools, the technology that is now available on the market. What we do at that time, we made only wake-up test, and after the distraction, we stop. The anesthesiologist raise in about it depends how were we trained to do this, but mostly in 10-15 minutes, no more. The deep anesthesiologists come out, and we order to the patients, but it was of course sleeping, but it was aware of our questions. Move your feet, move your toes, move your ankle, and that's it. At that time was finished. Of course, more correction you do to the spine, more problems you can create to the cord, to neurological tissues. So I started to use neuromonitoring in 1992. So it means 30 years ago. Of course, is expensive. It's expensive tool because you need a special team that knows how a machine works, how to use the needles in the skin, and so on. But I think in a country where this is very difficult to find, but you can use now also again the wake-up test, because the wake-up test is sure, but the most important thing is to train the anesthesiologist to do this. That's important because false negative and false positive are sometimes in your ordinary activity. So it's not your experience as surgeon, but the experience of an anesthesiologist team that's important, because they must create they from a deep anesthesiologist, they have to create a mild level where the patient is aware and conscious, is a prone position, is not a very comfortable situation, but he or she can answer to your questions. That must be done very clearly, and tell them, please move your toe and the left one, and she has to do. Move your right toe, and she has to do. Move your ankle, and that's important. Otherwise, you have to assist with your eyes to this. If not, something wrong has happened. Maybe the anesthesiologist had not done a good work, or you have done you have created something to the cord. That's the limit of a wake-up test, because you can't discriminate maybe which is the level of your problem. That's for me is the limit. But I think you can do scoliosis surgery with a wake-up test, but the anesthesiologist team must be very well trained. That's my idea. Okay.
Okay, thank you.
What do you think?
Yeah, I think you said it very correctly. That depends on the anesthesiologist.
Yeah.
So I think something we can work on.
You can use it, but you have to create a very good connection between the surgeon and the anesthesiologist.
Yes.
That's important, because otherwise, if the level of anesthesiologist is very low, is difficult to create a good team, and you are not doing a safe surgery, at that moment.
Yeah. Thank you.
You're welcome. So, other questions? Because I have a case to show you, to discuss.
Yes, just a question here. This is Albert speaking.
Yeah.
So when you have decided to do a selective thoracic fusion, how do we ensure intraoperatively that your residual curve has adequately reduced to an acceptable level, so that you think your thoracic fusion is adequate to correct both the main curve and the secondary curve?
Yeah, good question. So I totally love selective thoracic fusion, because as Dr. Lenke stated before, if you can spare the lumbar area in the fusion, of course, it's a great advantage for the patient, because he can do every kind of sport. On the other hand, the the selection of the lower part, not the upper part, because it's no problem if you stop in T2, 3, 4, not problem, because you know the thoracic area is less flexible compared to the lumbar area. But it makes a great difference if you stop in L4 or in T12 or L1. So the central sacral vertical line and the touch vertebra is very, very important. You have to clarify with using the tools that you have, which is the lower touch vertebra, and of course the bending films. Sometimes I always use selective thoracic fusion for Lanky 1 and 2. The difference for selective thoracic fusions is the Lanky 5. Excuse me, the Lanky 3. The Lanky 3, sometimes you have to stop in L4. Sometimes you can avoid to fuse the lumbar area. Why? How you can do this? You have, of course, you need experience, but you can detect how is two important things. How flexible is the lumbar curve in the bending films? Because, you know, they created the number 25 degrees, that is the limit between a rigid curve and a flexible curve. But sometimes this 25 is not so a rigid limit, you know. Why? Because sometimes in the bending films, you can arrive to 30 degrees, as Lenky shows. But if the rotation is not so high, and how you can see this in a very good clinical assessment, if you look at very carefully the lumbar area where the hump is not visible, that means I mean the prominence of the muscles of the lumbar area is not so prominent. That means that curve is not so rigid and is not so structured. And that in that case, you can stop and fuse only the thoracic area. That's important. You know, you can do the bending films, but also the supine film. And again, use the central sacral vertical line to detect which vertebra is touched by the line. At that point, you decide. But if you can, always try to not fuse the lumbar area. That's it's important, because but you need experience. You know, you need but you know, if you do a very good clinical assessment of a patient, sometimes you can identify very clearly in your head, in your mind, which are the proper level of fusion. During surgery, you can also see with a C-arm how is behavior of a not fused spine of a lumbar. Usually, you have a very good correction under deep anesthesiology and anesthesia and deep and the correction of a thoracic curve. You can see perfectly during surgery what's the result of your surgery. Okay, satisfied?
Yeah, thank you.
Albert,
thank you very much, Prof.
Yeah.
Massimo. Yeah, this is Kenneth. Another question for you.
Yeah. Oh, sure.
Could you hear me?
Yeah, I can.
Yeah. So, sorry, I'm going to take you back. Sorry, I'm going to take you back to just the basics. I'm still not sure yet very clear on how to determine the. I missed part of the lecture by Prof. Lenke, but I'm not really still very clear how you determine the extent of your fusion, especially if you're going to do, if, for example, let me say a length type 1, just major main thoracic curve. How do you determine the extent of your fusion? Yeah, when you're having your radiograph, there's a couple of parameters that are talked about: stable vertebrae, the neutral.
I can show you maybe.
I'm not really clear.
It's not okay. It's a great question, because the aim of this course is to you the basic of the fusion area for the AIS. You know, the basics sometimes are not so clear. You know, because if you do a lot, you need experience. You need to be trained. You need to see many cases around in your hospital. But anyway, I can try to, just a moment. I go in my files to see which case I can show you. Just a moment, okay? Give me 1 minute, 30 seconds. Not this one. Just a moment. Okay, this could be a good case to show you. Can you see here the patient?
Yes, we can.
Okay, so this is a boy of 15 years old. Okay, and when we do the assessment of this, what kind of curve do you think you find if you do an X-ray? You look at the shoulders. We have a right shoulder is elevated compared to the left one. You can see here. Okay, so we have, this is the left shoulder and this is the right shoulder. Okay, so this is high. When we have this and this, okay, totally asymmetric chest. Look at the scapula, here, and this is C7. This is the central, and this is probably the curve. Okay, so we can have in these two. Which kind of length do you think we have in this patient? Don't ask. Go ahead, please. Don't worry.
3.
So we can do a poll. So how many for free?
I think it's a double major curve.
3. Yes, 3.
Everybody is for free, or someone can think to have other kind of curves. Can be a number 2. We do for the exclusion. We can think about exclusion. Can this a lanky number 1? Yes or
Possible.
no? Possible.
Yes,
Okay.
it can.
Based on
No.
radiographs, could still be 1 if it
Yeah. Well,
the
now
number 1 is
later
correct with,
we
X-rays.
yeah now, but this is the first observation. A patient come in your office and this is the shape of the spine. So you can think in your mind that of course you need an X-ray and assessment, but always only looking at the shape of a trunk, you can know if this is a number 1, number 2, number 3. Probably, of course, probably because you need assessment with X-ray, but you can exclude for sure that if this is a number 5, for sure. Why?
Because it's not.
Because
it's not
exactly.
on the paracolumn. It's more on the thoracic.
Yeah. You can exclude also that it's a no. You can't exclude that it's a number 6, but of course you can exclude. You can't exclude that is a number 4. You need an X-ray, but for sure you can exclude that this is a number 2. So we go the next, and after this is the lateral view of the patient. Comparing thinking to the Lenke classification. This is a minus as normal or plus? Inversa.
Plus.
Who says plus? Azarias. Okay,
Be
just
normal.
a moment. Just a moment, Azarias, that I go to the chat. So okay. So this is, most of you have said plus, not normal, okay? When we go to the next, oh, this is important. Okay. So, which is a great hump, you know? Look at the hump. It's great hump, to right. But if you look here, it's quite symmetric. I don't see any kind of lumbar prominence. So the next, this is our, just a moment, this is our evaluation of the I go forward. This is our, I go back because this is in Italian, but you know, this is very important. Everybody has to use, this is the SRS 22 Scoliosis Research Society questionnaire, because this is very important for the assessment of the function of the scoliosis. Then also this is the visual, how the patient visualize himself. You see here, the patient knows that he has a big hump here because he selected this. And this is the curve. Okay? So, what do you think? This is most of you has said a good thing. Is this Elenchi free? How can you classify this? Go ahead, don't be shy. It's a course, we can discuss. Is this Elenchi 2? No. Because no. Why no?
Link 2 is the double thoracic.
I don't see any double. This is a non-structural curve. This is a non-structural curve. This is a very severe structural curve, and this is a non-structural curve, okay?
Yes.
Correct? What about the sagittal plane?
What?
We have to measure T2, T12 to know if it is a normal shape or is a probably is a little bit normal, because I don't see any kyphotic deformity, because this is the hump, you know, is not the this is not the real thoracic spine. This is only the image of a hump. So this is the thoracic area. This is the lumbar area. The pelvic tilt is quite normal. You know how this is measured with pelvic tilt. Remember this. This is the angle. This is the pelvic index. And this is the sacral slope. But it's quite normal here. We go here. Look at here, which is we say that is a lanky one. Okay, so what's going on? What happened? Okay, this is the CSVL, central sacral vertical line here. So this is L. Which vertebra is this?
L2.
L2. So L2 is the last touched vertebra. So touch vertebra is L2. So regarding what Dr. Lenki said, which fusion do you suggest for this patient?
So the fusion will end at L2.
Yeah, we can go from here, 1, 2, 3, from T3 to L2. It's correct. We go, we can see what happened. Oh, these are the bending films. Very rigid curve, you see? This is the assessment of our this is 44 degrees thoracic kyphosis, so it's a plus. Okay. But important thing is this one. Not this one. The shoulder, you know. This. The correction of a curve goes in the bending film to 37 degrees. That is more than 50% of corrections. And here, this is not the structural curve. Look at the shape of a bodies. There is no rotation. Rotation is very low. So of course, You can't go a long fusion until here, if you are 4. You can stop here. So you have this curve unfused, but it's very important for the patient, you know. And you see here, this is always we do a total MRI to. Why we do a MRI? Who knows? Why we do an MRI before surgery? Can someone reply?
We do MRI scans to check for malformations.
Yeah. We do MRI for avoiding a malformation, to detect if there are some malformation in the spine. Which kind of malformation we are looking for?
Syrinx, small nodules.
Yeah. Diastematomyelea. Arnold Chiari. Who knows? Neurosurgeons, please tell me what is Arnold Chiari in 1.
So basically, Chiari malformation is a small posterior fossa, might be associated with spinal malformations. So Chiari 1 is small posterior fossa with a tonsillar herniation.
Yeah, correct.
And Chiari 2 is Arnold Chiari malformation, usually associated with spina bifida. And it might have additional midbrain and hindbrain malformations.
Yeah.
And also some spine malformations too. Like tethering.
Yeah. Perfect. So when we plan to do a surgery in a case like this, always is better to do a MRI to know if there are some neurological malformation, because can they progress or worsen during surgery, you know. That's why it should be important to have neuromonitoring during surgery. Should be, and of course, but you can do a wake-up test, okay? So, and what have we done for this patient? It's totally normal. We don't have any syrinx. We don't have any tether cord. We don't have any kind of, you see here, the tonsils are normal. We don't have any Chiari malformation. So we can plan surgery. So coming back to the here. So we stop in L2 and we start from T3. Should be correct like this? Yes or no?
Yes.
Yes. Okay, good. We go ahead. And this is during surgery. Look at here. We have started with his under anesthesiology, you know. Look at the shape of the L of a lumbar curve. So in this case, we have decided to spare another. We have started with L2, but we have seen that you can spare another level and stop in L1. This is the positioning freehand of the screws. I always use reduction screws because it's better for the correction of a sagittal plane as well. And this is during surgery. You see all the reduction screws placed. And this is the correction. You see the maneuver. We insert the screws, when the rod, we do the derotation, and every level we do here also, and the apex in this area, the ponte osteotomy. That means that we remove all the joints so we can mobilize better the spine for the correction. And this is the correction of a curve. So we have done from from T4, yeah, T4 to L1 with a good, very good correction. Also in the sagittal plane, we have reduced the kyphotic angle. And this is the patient 2 or 3 days after surgery. Look at the sagittal plane, very nice. And this is 2 or 3 days after surgery, the shape. Look at the level of shoulder now is completely balanced, you know. Look at the shape of the flanks, completely balanced. So it's satisfied. Very good correction. Once only before and after. I see a great difference. What do you think? Do you like?
Very good.
Yes.
Yes.
That's an example of fusion, selective fusion with only fusion of a thoracic area, sparing the lumbar curve. So the life of this patient will be totally normal. He will do everything, every kind of sport, every kind of social activity. Okay. This is before and after. Sorry, is reversed here and after. Okay. And this is an example of what you said. So now
You're muted, Professor. Professor Massimo, you're muted.
okay. Sorry for this. Sorry for this. I want to show you this case, but it is very nice to discuss. Okay. Can you hear me?
Yes, please.
Yes,
Okay.
I can hear.
Okay. So we have this case. Okay. So we have, look at this case. I want that one of you can comment this, okay? So we have a case of a girl of 15.2 years, female. Her height is 151 centimeters. The weight is 41. BMI is 27.4. She had menarche 2 years before. So what do you say? First, how do you classify this girl?
I'll say length 5.
Pardon?
Length 5.
Who is speaking?
This is Albert here. Length 5.
Albert. Okay, Albert said that length 5. Other ideas? Everybody agrees to a length 5, or should we think to other kind of length classification?
Thank you, 5.
Length 5. Okay, Azarias. Who? Who was the last? Kenneth. Length 5 for you? Kenneth, length 5 for you?
Yes, length 5 for me.
Okay. Can I ask you why you think is a length 5? Why do you say it's a length 5?
The spherical lumbar curve.
Where is the apex?
L1.
The apex seems to be at L1. Apex L1.
Yeah, correct. Sorry, I can't. Okay. Okay, so this is the apex and is L1. What about the sagittal plane? Is the normal plus? You have to
neutral.
Neutral. So we think is N. Okay. This is the CSVL. Of course, the lanky 5 always are C lumbar modifier. And you are correct. This is a typical lanky 5. Okay? Very good. I'm very glad that you have done a good evaluation. So then we go to the clinical aspect. It's completely different from the case before. You know, this is the shoulder. These are the flanks are asymmetric. So this is the central line. And of course, you can see here the curve. Okay. So we go further. In the lateral view, it seems quite normal. You are correct. And this is, you know, we don't have any thoracic hum, but here in the Adams test, we have here the prominence of the L1, left one. So it's correct. What we do now? This is the SRS evaluation test that is divided in 5 subcategories. That means function. That 5 is normal, 0 is very low. Sorry. Oh, okay. Then pain, self-image, mental health, and satisfaction. For this girl, function is normal, pain is little bit underlined, self-image is not so good. She's completely normal with mental situation, mental health, but she's not satisfied of the treatment of everything connected to her scoliosis. So we have to propose something. So now, what we have to do for this patient? Classification, we have done. Radiological assessment, we have done. Other assessments, what do you do? What do you think? Dr. Mcharo, what do you do?
Maybe check for flexibility, what is structural.
You have to do some other radiological assessments. What kind?
Like bending film to see if it is rigid, how flexible is it.
Very good. So we go further. This is a software that we use to know in a proper way. This software is called Surgimap. It's not so expensive. I think you can download it for free from Google, from the web, and you can detect very clearly how is the angle of your scoliosis. Look at here. The main thoracic is the main thoracolumbar 46.1. The secondary is 20.4, and the other is 14, roughly 15 Cobb degrees. So, of course, this is the main curve that comes from the apex is L1, as you told, and what other important thing to detect? The apex of a non-structural thoracic is T6, T7, and the apex of the other non-structural is 4-5. So you see the great rotation we have here, exactly here in L1. So we go to see our assessments. That's important. But this is the supine film. You see, we have a nice correction of a curve. So is for some reason is very flexible, and here this is how you can detect the flexibility of a curve. So now we have done normal radiological assessment, this one, supine, bending film. Do you do some other assessments if you want? I have done this one. Why I have done this X-ray, the wrist, the hand of the left part? Why?
To determine skeletal maturity.
Have you studied? Okay, can you unmute someone? Have to unmute the phone. Why I have done this?
You want to determine the skeletal maturity.
Yeah, exactly. But exactly, I want to determine this. Have you studied the paper I have sent you about the Sanders classification or not? Can you hear me?
Yes, we can hear you.
I have done this because for some reason this is a typical, I have chosen this case because this is a typical case where we can do a lot of different treatments.
Yeah.
Because I have done also an MRI that is completely normal, so it's not syndromic, so as the previous case. So now we have these patients, 15 years old, roughly 47 degrees, flexible to 30. Okay, so later, have you seen the chat? You have to complete the quiz today, okay? Remember this. So, who thinks wait and see is a good option for this patient or not? Is a good option or not? Do you think this is a progressive curve or she can stop?
Sorry, can we not use the iliac crest and do research stage instead of doing?
It's better. I suggest to use both for some decision making, because you have to integrate the Sanders with a research test. In the papers I send you, there is a clear evidence that the progression of curve is different sometimes relating to the research sign and the Sanders sign. You have to study both. You have to use both. I go a little bit back here. Which how do you think can you classify this research sign here?
Yeah.
Is complete or not complete?
Almost there is a 4.
Pardon?
Almost there is a 4. Almost.
It's complete.
Not complete. No, we have this part is not fused. Is not fused with. So it's
incomplete.
It's not complete.
Yes.
Yeah, it's incomplete.
So if we go, so if it is complete, can we think to do this one? Wait and see?
No.
Why not?
I think the core angle is more than 30 degrees.
Yeah.
And she's growing, she's still growing. So the possibility that this curve will end up more complicated curve, I think, is very high. She's a girl. I think I will not wait. I will not wait.
Who agrees with Dr. Charo? Or who don't agree? Everybody agrees? Akimu.
I agree with him. Yes.
Akimu, what do you think?
Yeah, I do agree with Dr. Charo.
Him,
I can't hear you, but I think you agree. Good. So nobody wants to wait. So we do something different. Do we think physical exercise is a good option or not? No, there is no evidence that physical exercise can stop the progression of a curve, correct?
No.
So we do something, this is the line. So now we do something more structural. Can we think to use a brace?
Yeah, I will think of it. I'll think of the brace.
Brace is an effective and realistic technique to stop or limit the progression of a curve. Okay, but I tell you that this girl don't want to use the brace for some psychological problem. She refused to use the brace.
Yeah.
So now what do you do?
I think from the breast point of view, the compliance from the patient is very important. So the longer you wear the brace, the more the correction you like to have. So definitely, if she can't wear a brace, so probably have to discuss with her the option of surgery.
Yeah. So now she don't want the brace. No. Now we go for surgery. Okay?
Yes.
So Dr. Lenki has spoke about two kind of different technique. One was very well deeply stated, but He also had a briefly notice or non-fusion technique. What do you do for a patient like this? Who wants to fuse and who wants to use a non-fusion technique? Who wants to fuse?
I'll go for fusion. At least something which I'm more aware of.
Who want?
Age, I'll go for fusion.
Fusion.
Everybody goes for fusion? Someone thinks to the non-fusion technique?
I'd want to try non-fusion techniques since she's.
Yeah, non-fusion technique.
Because she still has some skeletal growth to do, so I would probably want to try the non-fusion technique.
Your connection is not so stable, but who are you? Who was the last speaking? No answer.
The non-fusion technique.
No, yeah, okay. No, the non-fusion technique is something more complicated.
Professor Massimo, my name is Kenneth Nyombi.
Okay.
From Kampala, Uganda.
Uganda, okay. So I go for the non-fusion technique you can use, but you have to be trained to do that. So I suggest in your
Can you
course,
hear me?
not so clearly. It's very disturbed line, but I understood that you like non-fusion technique, and you are right, because in this particular case, if you are trained and you are in your equipment, you have the non-fusion technique, you can also use, and that's why I have chosen for this girl the non-fusion technique. I show you. This is the result. We have done a vertebral body tethering. How we do this? We go from the convex side. These 3 screws are inserted in a thoracoscopic approach. Okay, with a thoracic surgeon, and this 1, 2, 3, I stop in L3, you see, so 1 level less of the touch vertebra, and these 3 are inserted in minimally invasive way in anterior approach of the lumbar spine, and this is the result. You see, before and after surgery, you see, in the middle of the body we insert the screw, and here there is the rod is an elastic. This is not a rod, it's like an anchor. It's like elastic rod. I usually say that comes from here, and then with a particular tool we can compress one screw to the other in order to correct the curve. This is the vertebral body tethering. You see the correction to 18 degrees, no fusion. After 1 day, she is able to walk. We use a chest tube for 1 day only, and she can be out of hospital after three days. And this is our scar, are very minimal. Here you see the scar here after 10 days. And you look at the aspect, the clinical aspect of the patient is very pretty. And you see here what happened after, this is after 6 months. So I think this is a good option. Of course, you can also use a fusion technique. It's not a mistake to use fusion for this patient, but for this particular case, I have chosen this non-fusion technique for some reason, because she's still in growth. She wants to be free of a brace. She wants to be, again, very active in the sport. She wants to recover very fast from the surgery. For some reason, if you are able to do a non-fusion technique, I totally think that is a good option for a patient. But we can also think to use fusion technique. In a case like this, I show you again that I was in the past. I show you again another case, sorry. Here. This is another lanky 5, you see here. A lanky 5 where of 57 degrees, okay? And this is again the lanky classification. I go very quickly to the next. So the important thing is where to stop distally, L3 or 4. Of course, if you can avoid, if you can stop in L3 is better, because you spare one level more of mobility. Okay. And but the critical points is to create a balanced spine on coronal sagittal plane without increase the risk of adding on for or accelerate the degenerative cascade of unfused segments. And for these patients, this is some papers. As Lenky said, in Lenky 5, you can choose both anterior posterior fusion for the correction of a curve. I prefer to use the posterior for fusion and anterior for do a non-fusion technique. And again, I show you very, very, very briefly the result. Look at how is the bending film. The correction is 57 degrees. And this is the shape of the patient before surgery. And this is the patient after surgery. In this case, we have done 78% of correction. And if you look at the behavior of a disc under the lower vertebral fuse, you see that the disc space are completely parallel. And this is very important. Why? Because when you see the behavior of this, you for sure you can avoid to fuse to L4, and for sure you can you look at here. You can spare to use the correction of the lumbar area less aggressive. Look at another case. 2 years after surgery, look at the behavior L3-4. It's completely the same. 7 years later, 9 years later, no problems. And for this girl was how do you say, a rider on horses, and she won a lot of prizes and races with fused spine. This is my report of Lanky 5 done in in 8 years, from 2010 to 2018, for 54 cases. You see the correction. And in main cases, I have chosen the L3 as the last instrumented vertebra. But in some cases, like this, you can't stop here. Why? Who knows why? Why you can't stop here? She is 55 years old. It's not an IS. Look at the age. Can you stop here? No. You have to look at this behavior of this disc. It's completely degenerated. So you have to stop here in L5. Okay. In fact, this is an adult, and you stop in L5 with a good correction. Sometimes you have to go further when is a subluxation of vertebra, which is 18 years old, but here look at the subluxation of the vertebra. It's very unstable, and you have to fuse more distally. You see completely unbalanced, and she is obese, and for this patient, of course, we need a long fusion and have to create a very well balanced spine. So last instrumented vertebra is a very challenging choice in Lenki 5. Anterior approach is still effective, but now posterior techniques seem to reach at least the same correction and segment sparings with a decreased complication rate and hospital stay. With careful address of the flexibility of a curve, rotation, L3 and 4 tilt is often possible to stop fusing L3, but balancing the spine in coronal and sagittal plane is mandatory. Further studies and follow-up need to confirm this data, but I'm very real convinced that when you can stop in L3 is better, and you avoid for young people further degeneration of the disc in older age. Okay, so people, guys, any question? Have you understood my presentation, the cases? Everything is clear or not? Tell me. I'm here for you.
This is great. Thank you.
I hope to come to Africa to help you in surgery. So you can, or you can mail me, because also we have some places for fellowship also from Africa. And if your government can help you to visit Italy, to my hospital, we are very open to accept to receive as host people from Africa. No, don't worry.
Thank you very much, Professor.
You're welcome. Okay, now I think you have to do your quiz.
Sure.
Okay.
Yes.
Okay, so I stop the room. I thank you, and we have the next week the cases. I suggest you to, if you have cases to present, bring in the presentation so we can discuss. Don't be shy. We are open to every kind of situation you can have in your practice, daily practice. Okay.
Yes.
Bye-bye. Thank you. Thank you.
Bye.
Thank you to everybody. Bye-bye.
Thank you very much.
Bye-bye. Bye-bye.